My name is Joachim Yahalom. I'm a radiation oncologist in the lymphoma group at Memorial Sloan Kettering Cancer Center in New York. I'm also the founder and chairman of the International Lymphoma Radiation Oncology Group, known as ILROG. And I'm here today to talk about those in indolent lymphoma, and that has gone through significant changes and may go through even more changes. Originally, the doses were high, like in all lymphoma, around 4,000 to 5,000 centigrade, and the fields were very large. And that was the way we practice 20 years ago and more. That has gone through dramatic changes, where first the fields were reduced for almost total lymphoid irradiation, treated the major parts of the body, all the lymph node stations, sometimes the spleen, to what we call now involved site, when we treat in localized disease just the lymph nodes, the area around the lymph node, so the site of treatment. And there are studies that show that this is adequate for follicular lymphoma and for marginal zone lymphoma, as well as for used in Hodgkin lymphoma and in the aggressive lymphomas topic by itself. In terms of the doses in follicular lymphoma, as I said, in the Jurassic Park time area, we used 4,500, 5,000. And then actually a British randomized study looked at a dose of only 24 grays, was a prospective randomized study, looked at local control of disease, and was used for both in the setting of palliation and relapse patients that were treated with chemotherapy, but also patients that were treated upfront with radiation as the only treatment with some patients with localized disease, potential cure. And this study showed that you don't need to go to 45 gray, and you get the same local control and the equivalent overall survival if you go to only 24 gray. So you go down from 20 to 30 treatments to only 12 treatments. At about the same time, there were kind of serendipitous observations of patients that instead of getting the designed 40 gray or so, received only 4 gray. Patient left the hospital, came back 3 months later, disease completely disappeared. And actually in Europe, several groups have looked at these very low dose that we call boom boom. It's only 2 fractions of 2 gray, and extremely low dose, not used in any other disease in radiation therapy. And these patients, a significant number of them had a complete response in the site that was irradiated. So the next step was again in the UK, led by my colleague Peter Hoskin, and that was a randomized study comparing only 4 gray, this new sort of dose, very low dose, to 24 gray. And in this study called the fourth study, follicular RT, fourth study that was recently updated in Lancet of Oncology, you see what you expect, and that is the 24 gray is superior to 4 gray, as everyone would predict. And the difference was with about 20% difference if you look at local control, but no difference in overall survival. So the question is, should we just stay at 24 gray as the author recommend, or get a different approach? And we call this approach an adaptive approach. And that's coming from the idea, yes, we achieve more with 24 gray, but what about 70% or 80% of the patients that are getting excellent response, sustained response with only 4 gray? The advantage of 4 gray is so significant because, this is no toxicity whatsoever, short-term or long-term. It can be repeated. It's only 2 visits to the hospital, and as we do it now is only 1 fraction of 4 gray, only 1 visit. So we decided to look at another option, and that's called an adaptive therapy, taking patients, giving them the 2x2 or the 4x1, and then asking them to come back in 10 to 12 weeks, or be re-evaluated, get another PET, and if they are in CR, just observe them, and if they are not, maybe give them just a partial response, give them some additional observation, but if they progress and we're not happy with the results, then we can complete the treatment to the full 24 gray. So again, if you can look at the empty side of the glass and say, well, 4 gray is not giving me the same results, and I have to be especially careful if I'm doing patients that are potentially curative. Then do I jeopardize their cure? Or on the other hand, that 70% of the patient can just get this meager 4 gray and do well, and there's no difference in survival. So we have decided to test this approach and do it in an adaptive way. So we give the patients 4 gray, 70–80% of them respond. They don't need any more treatment other than the usual observation. And those who have not responded adequately, we just add the treatment to 24 gray. So now we are actually testing it in patients who are potentially curative in a prospective randomized study that we are about to embark on under the ILROG multi-institutional study. And in this study, there will be 2 arms, the standard arm of 24 gray to early stage, potentially curable, untreated disease, and then we'll have 4 gray with the idea that around 10 to 12 weeks, we will evaluate and give more treatment if necessary, and observe if the response is adequate, or obviously complete response. When we have tested it in our retrospective series, and of course, there were patients were selected for this approach when they were potentially curable. First, we have seen that only very few patients required the additional radiation therapy, and we had no cases of transformation. That was the concern of our medical colleagues. So that has become very popular. And on top of it, now in the COVID area, when we wanted to minimize the exposure of patients coming to the hospital and reduce any intervention that can affect their immune system, we started to give these patients only a single fraction of 4 gray. We have already treated close to 70 patients with this approach, and we compared the results to our boom or 2 fractions, 2x2, and we see no difference. If anything, perhaps even a slight advantage. So I think we still have a way to go with follicular lymphoma. We cannot stop at the 4th study and say, well, 24 now is the holy gray, but because it was better in some patients than 4 gray, but test 4 with an adaptive approach. And that fits all the same direction that we do in hematological malignancy. We're trying to reduce the dose, individualize the treatment, and stay away from unnecessary toxic, either radiation therapy or chemotherapy. And I'll stop at this point.